All right, we have worked our way through an assessment, basically moving head to toe. Now let's talk about auscultation of the lungs. So first, just a quick hit on stethoscopes. I know you guys have used these a lot at this point. But we are going to hit this over the head a bit in lab because proper use of stethoscope is sort of taken for granted. So some things to know. The most important thing is that the stethoscope is placed directly on the skin, especially for lung sounds. I'm hoping you guys will try both over the clothes and under so you can hear the difference. It's amazing how just the slight friction of cloth sounds like a lung sound. It's very, very hard to hear lung sounds through clothing. Your earpieces should be really comfortable. Remember, your ear tips should always point at the patient. That aligns with your auditory canal. Way too often, I see people wanting to point them inward towards them, and then they have a hard time hearing. The diaphragm is the portion of the stethoscope that is the best for high frequency sounds. So the diaphragm is what we will use for lung sounds. The bell, or the smaller side of the stethoscope, is for low frequency sounds, and we will utilize this for some of our abnormal heart sounds when we get to that. The biggest thing when you auscultate the lungs is to do a systematic approach. It doesn't truly matter which side you start with as long as you follow a couple basic rules. One, you always compare right to left at the same level. So, if you start at this circle here, you immediately go to the other side so you can compare right to left at the same level. You are using your diaphragm for this listening. That's the best for lung sounds. At each one of the red dots, at each spot that you listen to, the patient should perform 2 complete deep breaths. We will talk about it here and again. This deep breath thing increases the sound. Lung sounds are so hard to hear, and a diminished lung sound might be a sign of a pathology, meaning when you can't hear it, it might be evidence of a pathology. It might just be that they're not breathing in deep enough. Because of the, if you do a full auscultation of the lungs, you might need to take breaks because this could cause a patient to get dizzy. So if you take a break at a couple levels, just make sure you always compare right to left before you go on. The next thing is to very consciously think about which lobe of the lung you are in. So you really need to know your anatomy. So at this point, you probably have had the lab where you drew out the anatomy, and it is important to appreciate where you are, because if you have an abnormal finding, you need to document where that was. So if you're looking at the picture on this slide, you can see, point number 1 at the top would be the apex of the lung. When you come down here, we're really looking at upper lobes. As you come down, we're looking more into the middle lobes, kind of, if you're on the right, the lingula, if you're on the left. Here we're getting possibly into lower lobes on the anterior side. Definitely if you're in the back, obviously. When you get down to 0.5, this is an area that would only be heard if you're on full inhalation, because the lung wouldn't be down that far during a resting breath. So knowing your anatomy is really important as you're doing your auscultation. All right, let's talk about what we hear when you are auscultating the lungs. So the first is just normal breath sounds. Normal breath sounds are called vesicular sounds, and this diagram, I'm not sure what to call my little indication here. These 2 lines are meant to give you a visual of what you hear. And if we kind of split it down the middle, this half here is your inhalation. and this side is your exhalation. So in a normal breath sound, you can hear the sound through the entire inhalation, and then the exhalation, you hear kind of the first half, 2/3, and then that sound just completely fades away for the end. I'll let you listen again. As the lung is emptying, there's less and less air moving underneath your stethoscope, so you can't hear it anymore. And that's why you lose the sound of the breath in your normal vesicular area. So if you look at the circle is representing where you'd hear that sound. So this is the sound you hear whenever you're in kind of the lobes of the lung. That is where you'd hear vesicular breath sounds. It would be normal and expected to hear inspiration being louder and longer than expiration, and then no pause between these two phases. It's just a continuous noise. The sound is soft and low-pitched, kind of a gentle rustling sound. The next one is bronchovesicular. Bronchovesicular is found when you are at the first and second kind of intercostal space in the front, or when you're between the scapula in the back. And let me move first onto bronchial and then hop back to bronchovesicular. Bronchial is the sound you hear when you place the stethoscope over the trachea. And it's very, very loud, high-pitched, almost like a hollow pipe sound. You'll see inspiration is the same kind of length and volume as exhalation, and then there is a pause between the two phases. This is because air is always moving through the trachea. There's never a point where air isn't moving unless you're switching between phases or at the end of one or the other. So let's listen to bronchial. Listen for the pause between. Very loud, tube-like. You hear it all the way on inhalation, all the way on exhalation, with that clear pause between the two. The reason I wanted to do bronchial and then hop back to bronchovesicular is because bronchovesicular is heard in the areas where these two other sounds overlap. So if you put your stethoscope in a place where there is kind of lung tissue and trachea, you're going to get kind of a combo of the two, and that's bronchovesicular. So that's why you hear this at the first and second intercostal space in between the scapula. And you can see it's kind of a mix of the two. So it's medium pitched, inspiration and expiration are equal in length and loudness, but we're missing that gap that we had with bronchial. Inspiration and expiration the same length with no break. Compared again to vesicular. A clear loss of sound during the exhalation phase when you're out in the lung tissue. So here's a really important point about these normal breath sounds. These are what you expect to hear, bronchial if you're over the trachea, bronchovesicular if you're kind of a mix between trachea and lungs, and then vesicular if you're out in the lung tissue. If you hear a normal sound in the wrong place, it's an abnormal finding. Let me say that again. If you hear a normal breath sound, but it's not in the right anatomical place, that is an abnormal finding. So a common example of that is you put the stethoscope out here in the lung tissue and you hear bronchial sounds. That bronchial is in fact a quote unquote normal lung sound, but it shouldn't be here. And it's typically evidence of fluid in the lung, and we'll talk through why that is in a little bit. Okay, so just because it's a normal lung sound, if it's in the wrong place, it is an abnormal finding. Let's talk about some other abnormal findings when listening to breath sounds. The first is reduced sound transmission, often referred to as diminished breath sounds. The reason someone may have diminished breath sounds is that they are a very shallow breather. If they're taking small volume breaths, less total air is moving underneath your stethoscope to hear, so it's really hard to hear anything. So if it's possible to take a deep breath, you can just ask someone to take a deeper breath and you should be able to hear that sound. But certain individuals wouldn't be able to. If somebody has, a restrictive lung disease where they can't take a deep breath, they may have diminished breath sounds. The other time you will hear less, make it harder to hear, is when there's reduced density. So if they have a hyperinflated lung, such as an emphysema, seen here in the chest x-ray, sound travels slower through air than through water. So if there's more air in the lungs, it's going to be harder to hear. So you might hear diminished breath sounds because of reduced density in a hyperinflated lung. The next one is that you can have evidence of increased sound transmission. So I mentioned just a second ago that sound travels slower through air than water, which the reverse of that means that sound travels better or faster through water than through air. So if there's an increased density in the lung, we would call this, in this slide here, we call this pulmonary congestion, or lung tissue that is filled with liquid. That's actually going to increase the sound transmission. So this might be a reason why you'd hear bronchial sounds. If you put your stethoscope right over this pulmonary congestion, you might hear characteristic bronchial sounds even though you're out in the periphery. There are some assessments you can do to kind of verify that you're having increased sound transmission. The worst, that's funny. The first is whispering pectroliloquy, which is you have the person whisper when you're listening to the chest with your stethoscope. Normally, in a healthy individual, and you can try this on each other, whispering should not be heard through the stethoscope. But if there's liquid in the lung and sound travels better through liquid, you'll actually hear the whispering. Another example you can do is bronchophony. You have the person say 99. Normally, this would be very hard to hear through the stethoscope. If there's fluid, the person's voice remains really loud in the periphery, and you can clearly hear the 99 through your stethoscope. The last one is egophony. You have the person say E, and in the stethoscope, you can hear A. I'm going to play this. I just want to warn you that the background noise on this is kind of loud, but you can clearly hear the egophony. Just be ready for a little staticky noise here. So that individual was saying E, and you could clearly hear A coming through the stethoscope. That would be a positive finding for lung consolidation. So louder, stronger sounds are evidence of consolidation. Longer, stronger sounds are evidence of fluid in the lung. The next group of abnormal lung sounds are adventitious lung sounds. Adventitious lung sounds are abnormal noises heard only with a stethoscope. And we can divide these abnormal noises into discontinuous and continuous. So the first one, our discontinuous sound, is a crackle. A crackle, which has previously been called a rail. So you can see on this little cartoon, it gives them as both. And this guy is eating Snap, Crackle, Pop Rice Krispies, which truly I think is one of the best descriptions of this sound, is the sound of like Rice Krispies. You hear like brief little bursts of popping bubbles. So crackles, the reason you might hear this is if somebody has collapsed alveoli, when they take an inhalation, that breath snaps those little alveoli open and you hear crackles. So this can be evidence that somebody is having atelectasis or small airway collapse. You can also hear crackles when there's fluid in the lungs, because as you inhale, the secretions kind of move between the alveoli and it makes that sound. So because of that, crackles are more common on inhalation. Here's some crackles. Next, let's look at continuous lung sounds. And I guess I should say by that, discontinuous lung sounds are a brief and intermittent, whereas continuous, you'd hear it through the entire phase of that breath. So the first continuous is a wheeze. And a wheeze is heard primarily, well, it can be heard on inspiration or exhalation. A lot of times we hear it on exhalation. And it has a constant pitch with varying duration, but it's associated with airway obstruction. So when your airway gets narrowed, it begins to make a sound during the exhalation phase. So an example would be bronchospasm. So if you've ever heard somebody audibly breathing during an asthma attack, you've heard a wheeze. If you have secretions that are narrowing an airway, it can also create a wheeze. That was a wheeze. It has been previously called rhonchi to discern from lower and higher pitched wheezes, but now clinically we're just using the term wheeze and then describing the pitch that you hear. The next one is stridor, which is associated with an upper airway obstruction. This is typically higher in intensity and pitch than a wheeze. Would be associated in like a peanut getting lodged in a bronchi. You might hear that noise. The last one is a pleural rub, which is evidence of pleural inflammation. So a description of this is almost like sandpaper rubbing together, or kind of the crunch, crunch, crunch of feet going into freshly laid snow would be two ways that I think of pleural rub. If you ever hear that noise and you're kind of having a hard time discerning between that and crackles, a pleural rub would never be altered by a cough. Where crackles, when it's because of secretions, if you have a patient cough, it can actually change the intensity, the sound, the location, or even clear the crackles sometimes, where a pleural rub would be unaffected by a cough. So when you perform a good lung auscultation, you'd want to document the sounds that you heard. If there was something abnormal and you use some kind of definitive technique like egophony or bronchophony, you'd want to report those findings. Name or describe your abnormal finding, where in the lung it was, and then provide your interpretation of that sound if possible. So I'll take 1 minute here to just discuss kind of why a PT would do this. We should be listening to lungs a lot more than we do because it really can help direct our plan of care, especially in a post-op situation. After somebody has had surgery, it's very common to experience some atelectasis or small airway collapse. And that may include secretions or not, kind of depending on a lot of factors in their larger medical story. But if they're post-op and they have a bunch of secretions, we should be incorporating airway clearance in our physical therapy because that is just a recipe for a pneumonia, which is one of the most common complications from these surgeries. If there's just airway collapse, maybe we just need to really encourage deep breathing when we're doing our normal mobility stuff. Like if you're not hearing the secretions, then that can be something that you don't need to worry about as much. Listening to lungs is just absolutely critical when we're treating patients with heart failure, because heart failure, if the heart is not pumping enough forward, because the overarching definition of heart failure is reduced cardiac output, if you're not pumping enough forward and fluid backs up in the system behind it, if it's left-sided heart failure, fluid backs up into the lungs. And one of the big reasons that this can happen is when the heart is overwhelmed and can't keep up, which happens during activity. So if you listen to the lungs before your therapy session and they are clear, then you get a patient up and they start walking or doing some other kind of mobility, and they have poor activity tolerance, they start desaturating, and you listen to the lungs and now crackles have appeared, you can actually describe an effect of your activity in relationship to how well their heart tolerated it, and that the fact that they couldn't keep up and it caused congestion. It's profoundly informative. You can use it for goal setting. You can use it to alter your plan of care, to adjust intensity of an exercise. It's a great indicator that's so easy to assess. Again, sometimes in the cardiopulmonary world, it's really hard to show progress because they might not physically do more, but they tolerate it better. So we'll talk about other places where you can set pulse ox as your goal, like perform, sit at your bed 2 minutes without desatting. Maybe day one they sat 2 minutes, but they went off the cliff. It's progress if they sit for the exact same amount of time and they don't desat. You can use auscultation of the lungs for that reason, to show progress over time as a feedback that the body is given. If you get involved in postural drainage where you're helping remove secretions from the lung, then auscultation is just absolutely critical. So it is this really, really easy assessment that does not take long, and it can guide decisions of your PT practice. All right, let's talk about some palpations we can do. The first is going to be assessment of the tracheal position. And we're actually going to go into detail about this in our discussion session. So I'll just leave it as the position of the trachea can give you information about changes of pressure and volume within the lung. And we will go into the full story in person in our discussion section. You can assess chest motion with your hands. It's so much easier to assess like kind of segmental contribution of the different sections of the rib cage, kind of upper, middle, and lower, by putting your hands on the patient, because you can see how your hands go for the ride, and it will give you a better assessment of their breathing pattern, and we will do this in class. Fremitus is when you have palpable vibrations when a patient speaks. So by just putting your hands on the patient, classically, we have them say 99 or 111, but really talking would work. And if you feel vibrations, that can be an evidence of consolidation. Again, that could be evidence that there is fluid in the lungs. Where not feeling anything could be an obstruction or a tumor, you could determine that there's less vibration. We can put our hands on the accessory muscles. I gave a video of a gentleman who was very, very obvious, but sometimes it's not clear if they're kicking these muscles in. So to palpate the use of these muscles, activation of these muscles, we can actually put our hands on and get more information. Palpating the diaphragm to feel how the diaphragm is contributing to their breathing pattern. We will do this in lab, where we will assess diaphragm contribution and do techniques to help facilitate diaphragm use in breathing. Palpating the chest wall for discomfort is really important when we're trying to separate out chest pain and discomfort from musculoskeletal origin and cardiac origin. If someone is complaining of chest pain, our immediate gut reaction is, my God, this person is having a heart attack in front of me. But we are clinicians that can assess this, right? Cardiac ischemia can never be induced by pushing on the chest wall, pulling on the muscles of the chest wall, contracting the muscles of the chest wall. If you can push it, stretch it, or contract it and recreate the pain, they are describing pain of musculoskeletal origin, which is extremely common, especially in patients that are debilitated, haven't used these muscles in a while, and those muscles can react painfully. So put your hands on the patient, assess where the pain is coming from. If you can recreate the pain in your PT evaluation, you are describing musculoskeletal pain. Cardiac ischemic pain should be brought on by exertion. Mediate percussion is, again, another assessment of density of the lung. You place the middle finger of your non-dominant hand in the intercostal space, and then you tap the nail bed with the other hand, kind of using your wrist like a fulcrum, back and forth in rapid succession. The lung should be very resonant. It's an open air filled space. If there's fluid underneath your finger, the sound will be kind of a dull thud. You can do this, you can test this on yourself by doing this procedure on your own lung and then comparing it just to your bare thigh. And you should be able to kind of hear that resonant sound of your tap on the lung and kind of just a thud on your thigh. And then that would be the sound if you were on the lung where there was an area of fluid. The final piece of a PT assessment is the activity evaluation and monitoring the patient's resting values or how they're tolerating supine, getting them sitting, getting them standing, if they can do some kind of ADL, if they can tolerate ambulation. Your activity assessment should be performed as soon as the patient is stable. You can absolutely assess somebody's response to activity while they are on a vent. If they've had a heart attack, we are getting these patients out of bed 24 hours after they're hemodynamically stable. Monitoring heart rate and rhythm, blood pressure, symptoms, all in response to this progressively increasing intensity of activity. Listening to heart sounds before and immediately after each one of these stages of activity to see how they're tolerating it, and then being the informed clinician ready to terminate exercise if there's an abnormal response that's making continued exercise unsafe. So there is a push for activity, physical activity, vital signs to be the fifth vital sign. How someone responds to activity should be just as important as, or more important probably, than their resting values. And this is our job. We can come in, we know how to safely do this and include this in our evaluation. I put this slide in here just as a reminder of kind of our threshold for oxygen saturation. It is not an absolute cutoff, but you should proceed with extreme caution when oxygen saturation levels are below 88 to 90%. And that is because of the oxygen dissociation curve and the fact that you transition from the linear phase, you transition from the flat plateau area into the linear phase where you get a rapid drop off of oxygen because hemoglobin has a lower binding affinity. We have to proceed very cautiously once we get below that threshold. We'll reinforce this again throughout the semester. So your evaluation is the formation of your clinical judgment based on the data gathered, right? The impact of findings on problems. We will formulate decisions regarding our intervention and place patients into a diagnostic group based on their primary dysfunction. I think at this point you guys are good with this, but obviously the PT diagnosis is not the same as the medical diagnosis. We need to come in and identify what their PT diagnosis is to appropriately prescribe physical therapy intervention. All right, so in our case, we decided to include an assessment of Ingrid's pulmonary status because she had abnormal findings. She was a smoker, she'd had a surgery, and she had a chest x-ray that revealed a hyperinflated chest with patchy areas of infiltrates in both bases. So let's just walk through the pulmonary assessment. First thing we want to do is our inspection, and we want to go head to toe. Her level of consciousness. She's alert and oriented ×3. She knows person, place, and time. Her appearance. She's slightly grayish in color, thin, slightly underweight. So grayish in color, having a pallor, might be indicative of potentially poor oxygen saturation, maybe increased sympathetic nervous system activation, but color is a little off. Underweight gives us our first indication of kind of nutritional status, exercise tolerance, maybe on the lower end, but not kind of a huge red flag. When we evaluate her neck, we see hypertrophy of her sternocleidomastoid bilaterally, hypertrophy as evidence of chronic increased work of breathing. So she came in because of a fall and she had a broken leg 3 days ago. This hypertrophy shows us that she's been working to breathe for a while. She has a forward head and she sits with the head of her bed elevated to 60 degrees, which may or may not be indicative of difficulty with the cardiorespiratory system. The reason I say may or may not is a lot of patients sit with their bed up, so it's not a definitive finding. When you evaluate her chest, you see upward movement of her chest with every breath, increased accessory muscle use, an increase in the anterior to posterior diameter of the chest. Remember, the anterior to posterior diameter should be about half of the transverse. When someone is hyperinflated, you increase that anterior to posterior diameter, and we see an increased respiratory rate. When we assess her cough, it's moist, non-productive, meaning she isn't coughing any sputum up, but is relatively ineffective cough. This is a red flag because she's going to be worse at clearing secretions, putting her at risk for a pulmonary infection. In her extremities, we see mild clubbing. Now we have our second clue of a chronic state of increased work of breathing and now chronic tissue hypoxia. Gray-blue color with tobacco stains, potentially some cyanosis of her extremities. When you do a lung auscultation, she has decreased breath sounds. Now, decreased breath sounds can be evidence of shallow breathing. It can also be evidence of reduced density. If she is hyperinflated, sound does not travel as well through air. It might be very difficult to auscultate breath sounds. She has some coarse wheezing. That would be an obstruction to her airway. And wet crackles on expiration in bilateral bases that slightly cleared with cough. That is indicative of fluid in the lungs. Those crackles, especially when they're cleared with cough. When you palpate, she has decreased chest motion, increased accessory muscle use, and decreased diaphragm excursion with palpable fremitus in bilateral bases. Another sign of fluid at the base of the lung. Here she had crackles at the base. Fluid is accumulating in a gravity-dependent position in her lungs. She has an ineffective cough, and she's not having great breath movement. Let's see what her response to activity is. At rest, her heart rate is 100, blood pressure is 110/70, and her pulse ox is 89. So this is a little tenuous of a position, but we still want to see how she responds to some activity. So let's go in a stepwise fashion. When we get her sitting up, her heart rate jumps up to 120. Right, you'd expect an increased heart rate in response to activity. This might be a little bigger than you were hoping for, but not yet a red flag. Her blood pressure drops to 90/66. So it appears she's having trouble maintaining her pressures, and she's trying to rely on heart rate to maintain cardiac output. Pulse ox falls to 82. We don't panic at this point. You might instruct her to try to see if she could sit up real straight, take a couple deep breaths. But if these numbers don't improve, you'd want to stop the activity evaluation. So you might give this about a minute to see how it's going. And if it does not improve, you would terminate. She couldn't tolerate standing because of increased pain and left in her leg, and she had some dizziness, which kind of match her vitals. So here's how we put all of that together. The patient is a 72-year-old female presenting with left hip fracture and an inability to perform basic functional tasks, including transferring sit to stand and ambulation due to pain, orthostatic hypotension, and poor oxygen saturation in the presence of signs and symptoms consistent with pulmonary congestion. These limitations put her at high risk for pneumonia and will likely impede activity progression. You have gathered just critically important information on how well this patient is going to do with therapy. And over the course of this semester, we are going to give you tools in your toolbox to add to your interventions to help get this patient moving safely, get her progressing, get her achieving kind of all of your typical PT goals, while accounting for and helping to prevent disastrous consequences like pneumonia that could leave her in the hospital longer or prevent her from being able to be discharged to the place where she really wants to go. So this was just the assessment piece. If I have you at the edge of your seat of how you could help this woman, stay tuned. You have about 3 months to go. This is what's coming next. All right. Thank you guys so much for your attention. I hope that a little part sparked some interest and inspiration to at least remember that there's some lungs in there and they play a huge role in our patient's ability to perform physical activity, and we have the tools to help. Those are coming up. Have a great day.